Today, we're going to be talking about a match made in heaven, glaucoma, and presbyopia-correcting IOLs. Now, when people think about glaucoma and advanced technology IOLs, a lot of people think that they don't go together. They think that glaucoma is a contraindication for advanced technology lenses. They have concerns about the potential for reduced contrast sensitivity, dysphotopsias, and the whole aspect of what's happening in glaucoma, which is the potential for progressive field loss. So one question is that as our patients, glaucoma patients, are they worthy of the convenience that does come along with advanced technology lenses and spectacle dependence, where they can have increased range of vision and also, if coupled with minimally invasive glaucoma surgery, less drops? Well, I say that the answer to that question is yes, a strong yes, but it does not have, the option is not necessarily there for every glaucoma patient. So, who are the good glaucoma candidates that advanced technology lenses can benefit? And when thinking about the answer to this question, there are some key considerations that we have to think about for who are those good candidates. And one of them is really to start with, what is the stage of their glaucoma? Are we talking really mild? Is it moderate glaucoma? Or are we talking severe? Because we kind of have to get a sense of where they are and also get a sense of what the trajectory of that glaucoma might be. And that might have something to do with their age, the etiology of their glaucoma, and also, like I mentioned, the stage at which they are. And then as we look at those things, we can get a sense of, are they controlled, uncontrolled? Have they been progressing pretty quickly? Have they been stable for a while? These give us a sense of where we are starting with the patient. Then we also have to consider when implanting these types of lenses, do we need to reduce medications? Is this a patient who, like I said, is controlled and stable on like maybe one or two medications? Are we looking at somebody who is uncontrolled, not even at target and on the maximum medical therapy? And this also plays a role into the ocular surface because we have to be thinking about where is their surface? Is it something that needs to be pre-treated? Do they have the potential to have some improvement in their ocular surface disease? And how aggressively do we need to address that? And then lastly, what's really important with advanced technology lenses is the patient interested in it. Not everybody minds wearing glasses, and some people actually like wearing glasses. So there does need to be some level of motivation for the patient to be interested in having access to these benefits of spectacle independence. So again, who is an ideal glaucoma candidate? Well, the most ideal are patients who are really mild. So your ocular hypertensive patients, patients who have really mild glaucoma, the kind of glaucoma that's very well controlled on few medications, and if any, and with visual fields that are very full or just really minimal peripheral defects. So nearly very good if they're pre-parametric glaucoma. So visual field like seen on the screen. Now, on the flip, obviously, who is a poor candidate for these types of lenses are patients who have advanced glaucoma. So we're talking about there's defects centrally, their glaucoma is not well controlled, they really have a high risk for progression, there's a heavy medication load. All of these things can be detrimental factors to the outcome for patients with advanced technology lenses. And so one has to start to think about, we have the extreme of who's really great candidate and the extreme of who's a really poor candidate, but then where can we kind of move into the middle zone? And that's where these newer technology lenses, the extended depth of focus lenses that we'll talk about, have allowed for a still good candidate to be someone who has not just mild glaucoma, but stretching into the moderate glaucoma with visual fields that are still just really peripheral. And so patients who have, yes, the ocular hypertension, but the mild and the moderate glaucoma that are controlled, or maybe they're uncontrolled, but the reach to control them is pretty easily reached with maybe adding MIGS to the scenario. These are patients, again, who have very full visual fields to moderate peripheral defects. So What's key in the preoperative evaluation? And this is really important because you have to evaluate the patient well, but then also set yourself up for success by allowing the patient and you to have a good sense of what the expectation should be. So this starts really with the visual field exam because this is going to give you the staging of glaucoma. You need to get a sense of where the patient is seeing, where they're not seeing, so that you can be able to assess whether or not the outcomes visually will be good and in line with what the patient is expecting. If a patient is very has really high expectations and you're not able to really kind of bring them down to the level that's realistic, they may not be the best candidate for a presbyopia correcting IOL. If their vision has if they have central vision loss, and that's not just from the cataract, but it's coming from the glaucoma. Again, one has to reconsider this as an option for the patient. So one of the things that I like to do is I like to look at the visual fields as I make my assessment, but then also include that evaluation and show the patient where they are. On the previous slide, I use this tool in my office to look at the visual field progression. And I let them know what a normal visual field should look like and explain that as glaucoma progresses, there's loss of vision temporarily in the peripheral area, but it can work its way towards the center. And this is what we're trying to prevent from happening. And then I take that and I show that against their own visual field. And what the patient can see is kind of where they are on that continuum. And they can see, okay, I let them know that this is where your glaucoma is. And then a cataract is like a film on top of this. Now we can take the cataract film away and we can put in a new clean, clear lens, but this area that is dark gray, this area will not go away because this is the glaucoma that is permanent damage. And so when we couple this procedure, oftentimes with a MIGS procedure, what we're doing is trying to help lower the eye pressure more so that we can prevent that downward progression of the glaucoma. And so as I explain that to patients and they see that in either eye, they can see which eye, it might be the weaker eye so that they know the expectations can be less with this eye compared to the better eye as an outcome. This really helps to set the stage for where they are and where they can get to. And so what we're trying to do is if they have a strong desire to have less spectacle dependence, try to help them have an improved visual outcome in the areas where they can see well, understanding that there are some limitations because of where their stage of glaucoma is. The other aspect of the evaluation is really also assessing the glaucoma status. So not just where the stage is, but are we controlled? And if we are controlled, what are we looking at to be able to get off of? A medicine or two? Are we looking that we're not well controlled, but we're trying to get there and it's realistic to get there? Maybe there's a 20 to 30% reduction that's needed to reach target, and those can be realistic with the MIGS procedures. Looking at the anatomy, looking to see if they're a MIGS candidate, looking to see which MIGS options are available to them, maybe looking at their insurance, being able to assess which MIGS might be covered by their insurance. All of these aspects are done at the evaluation to see how we're going to set that surgical plan up. Then we're also looking at the slit lamp, looking at the corneal surface. We're looking to see if there's any kind of corneal staining and if there is any kind of meibomian gland dysfunction, because these are aspects of the overall outcome that we need to address, and we might have to address them early on with the use of artificial tears or punctal plugs or utilizing preservative-free medications or vitamins or procedures that help with meibomian gland dysfunction like LipiFlow or iLux or Blefex. So different things that we might need to do to treat the patient to help them to get that best outcome. And then also we're looking at other anatomical findings that might be of concern. If you have a really small pupil, if there's a synechii there, is this a patient that could have a lens that you're concerned about how the pupil is performing? Maybe they're not a good candidate. Or there's someone who has pseudoexfoliation and there's already some zonular instability. The likelihood that they may have a dislocated lens later, if there are already some signs now, might make them not a good candidate. So these are things to be thinking about in your preoperative evaluation. So now you're here and you need to make that choice. What's the IOL going to be? And so when we're talking about advanced technology lenses, presbyopia correcting lenses, we're looking at multifocals or trifocals, and also the extended depth of focus lenses. And when we think about multifocal lenses, there has been a lot of thought about how they can be maybe not the best lens for patients with glaucoma. Now, with their design, they are made with rings, and it is such that this technology allows for there to be improvement of vision with spectacle independence at distance, intermediate, and near. And there have been reviews that have showed that these multifocal lenses can be of benefit in terms of quality of life, as well as decreasing risk of falls compared to monofocal lenses. However, there are caveats with these multifocal lenses because of their design, because one, they split light, and by splitting light, that causes a decrease in the contrast sensitivity, which is not good for patients like glaucoma patients who already have some limitation there and the potential for more in the future. Sometimes there can be an overall reduction of the quality of vision with these lenses, and that can be especially concerning for patients who already have trouble in dim light settings. And then also there's dysphotopsias, whether it's starbursts or glare or halos. These are also going to be a concern with patients who do have some issues relating to glare already because of their underlying disease with glaucoma. Uh, Now, those things that I mentioned are of concern, but there's also some other concerns that relate to diagnostic testing for glaucoma. There have been reports about how there can be, with multifocal lenses, artifacts in OCT readings that can affect the quality of those readings as someone is monitoring someone over time to assess their glaucoma. There's also been some papers that have shown that there is a decrease in the contrast and the visual sensitivity of visual fields that are there because of the multifocal lens. And so these are things to be also considering for patients who have glaucoma, and reasons why sometimes multifocals might not be the best option in those patients. But there have been some studies, very few, that have looked at the visual function and how patients are, their satisfaction with multifocal lenses in patient populations that include patients with glaucoma. There was a paper that was done by Sanchez, and in that, it was a retrospective evaluation of patients who had glaucoma or dry AMD. And in their assessment, they had at least 18 patients or 18 eyes that had some stage of glaucoma, whether early, moderate, or advanced, that they evaluated with having had a multifocal type lens. And what they found in their results were that the healthy patients and glaucoma patients that had preparametric visual field loss, or no visual field loss, they perceived halos more often than patients who had glaucoma, visually significant glaucoma, or dry AMD. And they also suffered less overall from glare. What they found in patients who had glaucoma and dry AMD is that they had more difficulties when driving at night. And also that patient population required spectacle correction for near vision more often than the other groups. But overall, what they concluded is that the healthy patients and preparametric glaucoma patients were very similar. And that led to the idea that it might be very okay for patients who are in that category to be able to benefit from multifocal lenses. And so Where one can maybe think about where to fit multifocal IOLs with glaucoma patients is in patients who have ocular hypertension, patients who are glaucoma suspects, the preparametric mild glaucoma, patients who have anatomical angle closure, where their nerve is very healthy. These are patients where multifocals can fit in that kind of class of really mild glaucoma, really early stage or just borderline glaucoma. And then we're moving from the multifocals to talk about extended depth of focus. And one other place where the patients may benefit in this category are also with the trifocal lenses, patients who have early glaucoma. So now moving into the extended depth of focus IOLs. These lenses came out to provide another opportunity to provide extended depth of focus where the vision at distance and intermediate was really good, and then there was some level of functional near vision. So just an extension of that range. And these lenses have been found to, compared with monofocal lenses, be somewhat comparable in terms of their reduction in contrast sensitivity, which is much less and much less noticeable compared with the multifocal lenses. Now, the first lens that we'll discuss that's an extended depth of focus lens is the Tecnis Symphony lens, which came out in 2016. And again, this was with a evaluation of this lens showing that there was less contrast sensitivity with this being a diffractive extended depth of focus lens. And the technology that allowed for the ability to have that extended range and that improvement in the contrast sensitivity was the design. The Echelet designed feature, what it did was allow for an elongated focus to extend that range of vision. And then the proprietary achromatic technology, what that did was it helped reduce chromatic aberrations for an enhancement in the contrast sensitivity. So with those two features within the design, this allowed for that extended range. And as we see here, on the defocus curve, we are able to sustain visual acuity of 20/20 at distance, and then when extending that out through 1.5 diopters of defocus and that into the range that should be intermediate, we're still seeing vision of 20/20 at that intermediate range. And then when extended further out, for the range where it's near, we're still getting some good vision at that distance. I have utilized the Symphony lens on a small number of glaucoma patients, and with one of my mentees, a resident at Eastern Virginia Medical School, Patrick Wu, we were able to collect some of that data preliminary, and I want to show you those results. So these are visual outcomes of the Tecnis Symphony lens in glaucoma patients. This was a retrospective cohort study. We investigated patients who had mild to moderate glaucoma and ocular hypertension. We ended up with 24 eyes of 15 patients. And we were looking at main outcome measures of uncorrected and best corrected visual acuity at distance, intermediate, and near. And then we also looked at the spherical equivalent, the cylinder refraction at 1 year mark, and then also looking at the reduction in eye pressure and number of glaucoma medications for patients who had a MIGS procedure done at the same time, and then whether or not there was any need for additional procedural treatment. The mean age was 69.22 years. The gender was mainly females at 70.8%. The race was a mix of 79% Caucasians and near 21% African Americans. The laterality was about equal in both eyes to right and left. The mix of the demographics, we had about 21% ocular hypertensives, 50% were primary or mild open angle glaucoma, about 12.5% being moderate primary open angle glaucoma, 16.7% being other types of intermediate correction, other type of secondary glaucomas, all being either mild or moderate. And then patients with concurrent MIGS treatment at the time of surgery was 79.2%. And so what we found was that there was a significant improvement in best corrected visual acuity at 6 months and 12 months when compared with preoperative best corrected visual acuity, which was significantly, statistically significant for both. There was about 57% of eyes that achieved an uncorrected visual acuity of 20/25 or better. The mean 3 to 6 month postoperative vision or uncorrected distance vision was equivalent of 25.5 in Snellen. The uncorrected intermediate visual acuity was equivalent to 21.1 in Snellen, and the uncorrected near visual acuity was equivalent to Snellen 20/2036.2. So overall, all eyes were able to achieve an uncorrected visual acuity, intermediate visual acuity of 20/25 or better, and for near uncorrected was at least 20/40 or better for all eyes. The mean spherical equivalent was 0.06 diopters. The mean cylinder was 0.3 diopters for the final refraction. And there was a significant decrease in the number of glaucoma medications at 1 year. There was no significant difference in the IOP at 1 year. And that goes to showing that a lot of these patients were fairly well controlled and were looking for a drop in their eye pressures. There were no complications intraoperatively. There's one patient who did need additional MIGS treatment for eye pressure control. So overall, in conclusion, we felt that the Symphony lens, Techno Symphony lens, did yield good visual outcomes with a good safety profile in patients who had ocular hypertension and mild to moderate glaucoma. So moving to another type of lens, which is a newer extended depth of focus lens, the Acrosoft Vivity IOL, which came out in 2020. This design was different in that it was a non-diffractive technology with no rings. And with it, there was a good reporting of decrease in dysphotopsias, so less starburst, halos, and glares, and very similar to what was that seen with monofocal lenses. So with this lens, there was monofocal monofocal quality distance vision with excellent intermediate and really good functional near, reduced dysphotopsias, as I mentioned, and that non-diffractive technology. And without the rings, there's no splitting of the light. So with the clinical trial, the Vivity lens was able to show 20/20 at distance, greater than 20/25 at intermediate, and then 20/32 for functional near. And looking at this just focus curve, one of the characteristics of the lens is that it is very considered very flexible and forgiving. As you look at the defocus curve, there's a very flat landing zone. And so at distance, one can be just a little bit off, but still get a very good, excellent distance vision. And then as one moves down the defocus curve to the area of the intermediate vision, one still gets excellent 20/25 vision at intermediate. And then as you pull towards where near is, the vision goes to about between 20/30 and 20/40. So good functional near vision. And with this technology, what makes it unique is the non-diffractive X-wave technology that what it does, it stretches light and shifts it, but there's no splitting of the light. And the unique aspect is when you look at the lens, it can look very much like a monofocal lens, but in the right angle, you can see that there's a slight elevation of the central element, which is what gives the ability to stretch and shift that light. And in here you have the slide showing how the light intensity is distributed or assimilation of that. And in the first line, you have the Acrosoft monofocal lens, and you can see that there is a stretch of light. There's no splitting of it, but it is limited in how far it goes in terms of the depth and the range. With a symphony lens, this is a diffractive lens, and so you see that there is an elongation of how long it extends, but it's not a clean extension of the light without any areas of some small areas of loss. Or splitting, there's some splitting there. With the panoptic trifocal lens, again, now you see the stretching out. There's areas of some loss of the light because of the rings, but it is able to have the areas of stretch from the distance, the intermediate, to stretch all the way into the near with excellent vision at near. And then you have your Vivity, Acrosoft Vivity technology, where you see here there is no splitting of the light, and it stretches all the way from intermediate, the distance in intermediate, and then close to the near, giving that functional range of vision. And then here is a depiction of the differences between having a diffractive lens versus a non-diffractive lens. You see the optical bench halo measurements giving an indication of where you are with a monofocal lens. The Acrosoft monofocal lens shows a very mild amount of glare. The Vivity lens shows a very similar amount of glare to the monofocal. And then when you look at the Symphony diffractive technology, you see that there's an expansion of that glare that's much more due to the nature of the lens. So I also, with a medical student from Eastern Virginia Medical School, Lauren Mason, did some looking at some of the data for some of our Vivity patients who had glaucoma. This was a retrospective case series. We looked at patients who had mild, moderate, and severe glaucoma who underwent having the Vivity lens. Also, there were patients who had anatomically narrow angle and ocular hypertensive patients. There were 22 eyes of 17 patients. Main outcome measures were looking at uncorrected and best corrected distance, intermediate and near visual acuity. And we were looking for a reduction in IOP and the number of glaucoma medications. So looking at the demographics, the age was 67.3. The gender was mostly females at 58.8%, and the race was a mix of 58% Caucasian, 35% African American, 6% Asian. We also had laterality was equal in both eyes at 50-50 right and left. In terms of the types of glaucoma, there was 50% that had mild primary opening glaucoma, near 14% that had moderate primary opening glaucoma, and about 27% that were considered severe. Ocular hypertension was at 4.5 or 4.5%, and other at also 4.5%, other secondary glaucomas. And patients who had concurrent or prior MIGS was all of these patients, 100%. So there was a significant improvement in terms of the best corrected visual acuity at 1 month and at 3 to 6 months when compared to the best corrected visual acuity at a baseline. And this was statistically significant. 68.4% of patients achieved an uncorrected distance visual acuity of 20/25 or better. The mean 3 to 6 month post-operative uncorrected distance vision was equivalent of 20/25.8 at the uncorrected intermediate visual acuity at 3 to 6 months postoperatively was still an equivalent of 20/20.6. And for the uncorrected near vision at 3 to 6 months postoperatively, it was still an equivalent of 20/39. So there was also, looking at the glaucoma side, a significant decrease in the number of glaucoma medications. There was also a decrease in the significant mean of the eye pressure, a 3.43 millimeters of mercury drop. And then one patient did have require an IOL exchange due to decreased vision, and that was a patient who had severe glaucoma. So overall, concluding, the extended depth of focus Vivity lens can improve the uncorrected visual acuity in eyes that have both cataract and various stages of glaucoma combined with mixed procedures. So that showing some signs of some good results with the extended depth of focus IOLs and glaucoma patients. I now want to look at a case. This is a patient who had a 77-year-old female who had glaucoma and a visually significant cataract referred by her optometrist for evaluation. She was very active and wanted the best vision she could get with the least amount of glasses. She was on Zalatan once at night in both eyes, and her pressures were 17 and 19 in the right and left eye, respectively. Her pachymetry was normal. Her slit lamp exam revealed that she did have some mild dryness with SPK. She also had some signs of meibomian gland dysfunction in the lids. Her cataract was showing NS of 3 to 4 plus with 3 plus cortical changes in both eyes. She had cup to disc ratio of 0.5 in the right, 0.65 in the left, with superior thinning and an early notch. She also had on gonioscopy wide open angles. And on visual field in the right eye, there was an early superior arcuate, and in the left eye, there was an inferior arcuate into a nasal step with some encroachment close to cecocentral fixation. The OCT did show borderline inferior temporal and temporal thinning in the right eye and superior and temporal thinning in the left, as seen here. So we did preoperative measurements. We do a number of them in order to get some level of consistency in our measurements. So we did LensStar, NIDEC, OPD, and the Cassini, looked at her Ks, which were consistent, and then also did additional measurements of looking at her refraction with also doing the LensStar and Cassini looking at signs of her level of astigmatism. And so the surgical plan, given that she had a decent amount of astigmatism, was to use the Vivity toric IOL, 20.0 diopter DFT 315 at 170 degrees. And we then combine this with goniotomy procedure, trabectome. Also of note, prior to the surgery, we did address ocular surface dryness using artificial tears and her meibomian gland dysfunction using an iLux procedure. The second eye was very similar in calculations. She didn't have as much astigmatism, so our surgical plan was for a Vivity lens, a 20.0 diopter DFT 015. We used laser, LensX laser LRIs in order to help correct her mild astigmatism. And then we combined that also with the trabectome goniotomy and did pre-treatment as well as we did in the other eye for her meibomian gland dysfunction and dryness. So her outcome was excellent. Her visual acuity in the right eye at distance was 20/20 -2, at intermediate was 20/20, and at near was J3. For her left eye, her distance was 20/25 -2, her intermediate was 20/20, and her near was at J2. And so overall, with both eyes binocular vision, she was 20/20 at distance and intermediate and J2 at near. And she was very ecstatic about her eyes, wanted to tell everybody that they should get their eyes done. And her pressures were also much better controlled, now on no medications at 16 and 15. Now, I wanted to show a video of the Vivity using the video, and in this case with the iStent inject. This is a patient who's had LensX laser, and we're marking the area of where we want to line the lens for astigmatism correction. Here I am doing a phacoemulsification and doing a removal of the cataract with cortical cleanup, doing some polishing of the posterior capsule. I then insert the Vivity lens, and upon insertion, I'm able to kind of line it up, but not exactly, because after I do the MIGS procedure, I will then come back to align the lens. So here I've placed the lens in the capsular bag, and now I'm going to make some adjustments with my microscope and my seating position to get ready for the eye stent. So here I'm doing my placement of the eye stent, shifting a little bit so that I can place it close to where my target is. You see the purple lines, those are close to my target of the episcleral vessels for good outflow. There's me tapping it into place, and I see a little reflux heme. So now I center back, and I use my Sinskey hook to kind of move the lens to the side so that I can go in with my INA to remove as much viscoelastic behind the lens as possible, just being very careful of that posterior capsule that likes to sometimes sneak up into that IA. So I'm removing that so that when I seat the lens, it will kind of seat in a good position against the posterior capsule and not do much movement or slippage. And so here I'm doing a very good removal of viscoelastic, and then here trying to center that lens. And you can see at some points you can't tell that it's even a Vivity lens because it's hard to see those lines. But when in the right kind of positioning, you do see it there, trying to make sure that those three dots are aligned in the center. So when we think about extended depth of focus IOLs and where they'll fit in with glaucoma patients, like with the multifocal lenses, the really mild glaucoma, your ocular hypertension, your glaucoma suspects, preparametric mild glaucoma, anatomical angle closure, those all fit with this. But then also you can consider extending to the mild to moderate, moderate glaucoma patient who is controlled, who one has some sense that they've been controlled over a good period of time, so their level of progression is less likely to be quick. And so those are also good candidates for these presbyopia-correcting IOLs. So, in conclusion, some takeaway points are that there are options that are available for patients who have glaucoma, that they can have some reduced dependence on spectacles or glasses. They can also have good vision, and this can also be coupled with MIGS and have less dependence on drops as well, which in turn can actually help with the ocular surface, improving that. But we need to offer them to the right candidates. It's not for everybody. And it's really important, extremely important to set the expectations to get the best outcomes and to know that one can really easily marry these MIGS procedures with advanced technology lenses to get good outcomes. I'd like to give special acknowledgement and thanks to Patrick Wu and Lauren Mason, my mentees who are very helpful with the collection of data that we are planning to still continue to contribute to and do a post survey for the patients to get their assessment of their satisfaction of the IOLs. And also, I'd like to invite you to check out my eye glaucoma YouTube channel, where we do lots of educational videos on all types of glaucoma. We have a series that's ongoing called the MIGS Success Surgical Secrets, which we're now getting ready to enter into season 2 coming soon. So thank you so much for your time and your attention.